In Module 11, we will be discussing the following: the classification of obesity as a disease or a health risk, how overweight and obesity are defined, caloric balance and why physical activity and exercise are important in achieving it, and the prevalence, economic costs. When it comes to overweight and obesity, we may want to think of the following open questions: what makes someone overweight or obese? Why is this such a problem? What criteria are used to determine whether someone is overweight or obese? What evidence exists that suggests physical activity can help with weight maintenance, weight loss, and the prevention of weight regain? How much physical activity is consistent with weight maintenance, weight loss, and the prevention of weight regain? According to the U.S. Surgeon General, overweight and obesity have become major health problems in the U.S. The World Health Organization announced that worldwide obesity more than doubled between 1980 and 2011. And that 65% of the world's population lives in countries in which overweight and obesity kill more people than underweight. Overweight is defined as carrying more body fat than is healthy or an amount that increases disease risk. Obesity is defined as having an unhealthy body weight, which is consistent with a variety of disease processes such as cardiovascular heart diseases, metabolic syndrome, and type 2 diabetes. Then, are overweight and obesity diseases themselves? The answer depends on the definition of disease and which professional organization, government office, corporation, or foundation you talk to. Overweight is not considered a disease but has been associated with numerous health consequences, and although obesity has not been officially recognized as a disease in the U.S., private and government insurance groups have been reimbursing people classified as obese by physicians for special foods and weight loss programs and procedures since 2002. In this module, we will review key ways to measure obesity, overweight, and body composition. Body mass index or BMI is a common measure to classify adults and youth as obese, overweight, normal weight, or underweight. It is a frequently used screening measure that takes into account a person's height. To calculate BMI, divide weight in kilograms by height in meters squared. For instance, a male adult weighs 80 kilograms, and his height is 1.80 meter, then his BMI will be 80 divided by 1.80 squared, which is 24.69. Then, how can we define the terms obesity and overweight for adults using BMI? Adults are considered overweight if their BMI is greater than 25.0 kg/m2 and obese if their BMI is greater than 30 kg/m2. This table shows the weight, BMI, and status for a sample height of adults. It is clear that those with a BMI between 18.5 kg/meter squared and 24.9 kg/meter squared are normal weight, and those with a BMI lower than 18.5 kg/meter squared are underweight. Adults are considered overweight if their BMI is greater than 25 kg/meter squared and obese if their BMI is greater than 30 kg/meter squared. When we work with youth, we should not use the same classifications. Then, how can we define the terms obesity and overweight for youth using BMI? Children or adolescents are considered overweight if their BMI is greater than the 85th percentile for age and sex. They are considered obese if their BMI is greater than the 95th percentile for age and sex. You may wonder, is BMI accurate in assessing body composition? Why? The answer is no. Although BMI correlates with measures of body composition such as fat percentage, it does not directly measure body composition. BMI measurement does not take into account the specific components of body composition such as lean muscle mass versus fat mass. Therefore, A person with high amounts of lean muscle mass like an intercollegiate athlete may be misclassified as being overweight or obese using the BMI. For example, my BMI usually would be 25.5, yet my body fat percentage is 16.2% as measured a few weeks ago. This is the key limitation of using BMI, particularly at the individual level. Taken together, BMI is not meant to be a clinical diagnostic tool. Rather, it is a useful screening mechanism and can be helpful in a complete physiological health assessment. The two figures on this slide demonstrate the growth charts of boys and girls from Centers for Disease Control and Prevention. The left figure shows the BMI for age percentiles for boys between 2 years old and 20 years old. The right figure shows the BMI for age percentiles for girls between 2 years old and 20 years old. I believe that, when you were young, you may get your BMI percentiles every time you visited your primary care physician. Standardized growth charts are used to classify children and adolescents based on BMI. Growth charts consist of a set of percentile curves that illustrate various growth trajectories based on a standardized population. Percentiles are relative to a no distribution or population and are used as a standard against which others can be measured. Knowing sex, weight, and height, and age, we can use a growth chart to estimate the percentile of BMI. The two figures show the examples of BMI integrated into growth charts. A basic understanding of energy expenditure and caloric balance is essential for a more detailed understanding of the relationships between exercise and physical activity, and overweight and obesity. Although we primarily focus on energy expenditure to achieve caloric balance, energy intake such as the food you eat is clearly important as well. A simple caloric balance equation scale is shown on this slide. We will elaborate more in the coming slides. Next, I would like to talk about energy expenditure and energy balance. Total energy expenditure is the total amount of energy, typically measured in kilocalories, that is expended over a specific time period, usually measured over a 24-hour period. There are three major components of total energy expenditure. These include basal metabolic rate, thermic effect of food, and physical activity. The percentages provided in the slide are estimates that are typical for a sedentary individual, and these estimates will vary based on an individual's physical activity status. For example, the contribution that physical activity makes to total energy expenditure is greater for active individuals compared to their sedentary counterparts. In detail, basal metabolic rate accounts for approximately 70% of total energy expenditure. It refers to kilocalories your body needs to properly function while at rest. Thermic effect of food refers to kilocalories your body uses when it is digesting food, and explains approximately 10% of total energy expenditure. Physical activity accounts for approximately 20% of total energy expenditure, and it is the most variable component of total energy expenditure and is divided into two main components. Activities of daily living such as bathing, eating, and grooming, and variable activities such as sports, leisure, and occupational physical activity. Here comes the content of energy balance. Ensuring optimal health and maintaining a healthy body weight is accomplished through sound dietary practices and participation in regular amounts of physical activity. Energy balance is the difference between the number of kilocalories that you eat energy intake and the number of kilocalories that you burn energy expenditure. If energy intake is greater than energy expenditure, then you are said to be in positive energy balance. An individual in positive energy balance will gain weight. If energy intake is less than the amount of energy that is expended, then you are said to be in negative energy balance. An individual in negative energy balance will lose weight. If energy intake is equal to the amount of energy that is expended, then an individual will maintain his/her weight. As known, the prevalence of obesity and overweight is at pandemic levels globally and in the United States for youth and adults. Then, what is the current U.S. prevalence of obesity or overweight in adults? In the United States in 2010, more than 67% of non-institutionalized people over the age of 20 were overweight or obese. The World Health Organization 2011 estimated that at least 1.5 billion adults over age 20 are overweight, and 200 million men and almost 300 million women throughout the world are obese. New data should be available on CDC and WHO websites. The trend of an increasing prevalence of overweight and obesity among children and adolescents over the past 40 years is also disturbing. Obesity trends among children and adolescents from 1963 to 2008 is shown in the next slide. Then, what is the current U.S. prevalence of obesity or overweight for children and adolescents? In the United States in 2010, at least 16.3% of youth between the ages of 2 and 19 years are obese. Since the 1960s, prevalence of obesity among children ages 2 to 5 years increased from 5 to 12.4%. Among children ages 6 to 11 years, it has increased from 6.5 to 17%. And among adolescents ages 12 to 19, it has increased from 5 to 17.6%. The rates for youth classified as overweight have also increased significantly since the 1960s. As we can see here, since the 1960s, BMI among children ages 2 to 5 years increased from 5 to 12.4%, among children ages 6 to 11 years, it has increased from 6.5 to 17%. And among adolescents ages 12 to 19, it has increased from 5 to 17.6%. Preventing childhood overweight and obesity is very challenging. Research demonstrated that obese youth may be more likely to become obese adults than are youth who are not obese. This situation increases the risk of chronic, non-communicable diseases such as hypertension, high cholesterol, and type 2 diabetes. The economic costs of overweight and obesity in the U.S. vary considerably based on how they are categorized and estimated. Obesity and overweight either directly contribute to the development of costly chronic disease processes, or they complicate the medical treatments associated with managing the diseases once diagnosed, or both. The estimated total costs for the U.S. in 1998 may have been as high as $78.5 billion, which includes medical expenses for both overweight and obesity. The economic costs of obesity and overweight have been predicted to double every decade. By 2030, if obesity prevalence levels in the United States do not change, the economic costs will reach 15.8 to 17.6% of total U.S. healthcare costs. The data of trends in economic costs due to physical inactivity and excess weight are illustrated in the figure. The researchers analyzed the economic costs that physical inactivity and excess weight combined had on the U.S. economy in 2003 were about $450 billion, and have exceeded $708 billion in 2008. There are major health consequences of overweight and obesity. Then, what are 5 common consequences of obesity? Answers may vary but may include the following: coronary heart disease, type 2 diabetes, cancers of the endometrium, breast, and colon, hypertension, dyslipidemia like high total cholesterol, or high levels of triglycerides, stroke, liver and gallbladder disease, sleep apnea and respiratory problems, osteoarthritis, and gynecological problems such as abnormal menses, infertility.